So truly, you know, what we see today as well is how the system of Saudi Arabia as well, with the support and with the actually commitment of Dr. Rabia and the King Salman Center to bring these people almost 20 years later to really keep continuing to build this capacity. And this is not easy. I'm sure you know the team who worked very hard to really put this on today and reaching to this you know, International Day, made sure that we really keep them integrated within the communities. And this is very important. I think the parents and the community, if they know this is happening, they will become very supportive, and as well the legal rights will be as well observed and as well committed to.
Thank you very much. And I know, Nancy, you wanted to follow up on that.
Yes, I was just thinking a bit about some of the important players in the work that we do, both at the ground level and at the highest levels. And I always say, you know, for a ground operational organization like International Medical Corps, one of the most important kinds of support that we can get, whether it be from Chaos Relief or USAID or DFID or so many other governments and foundations around the world, is the flexibility to identify what the gaps are in an environment, in a community, and then to figure out creatively, based on what's happening in that community, how to help. And it requires a lot of flexibility, especially in conflict zones or after natural disasters like earthquakes and tsunamis, where we also responded. Because the environment on the ground has changed. It's changing every week. Sometimes it's changing every day. And so that kind of donor flexibility that allows organizations to make the right judgments and to make the right decisions based on the needs of the people that we are serving, and the fact that what maybe worked last year no longer works anymore. And so these donors I mentioned, and many, many other donors, play a critical role in helping us to reach people and to really affecting the change that we need to in these communities and really save more lives more efficiently. So I just wanted to mention that as an important part of this whole arena of trying to help people and reach people where they are, given that their environment changes all of the time.
Okay, thank you so much for that, Nancy. I want to close out by putting a final question to Dr. Arabia. I did a little bit of reading on the conjoined twins, and it's quite fascinating what's emerged. For example, conjoined twins having a higher mortality rate, and also female babies perhaps more likely to survive than males. But there are also geographical disparities. So you've got twins, a slightly higher instance of conjoined twins in Southwest Asia and Africa. So given all of these realities and the medical realities that you have confronted in your work, my question to you is, what are the strategies that need to be developed for timely intervention and, above all, coordination to support the twins and their families, particularly those who are coming from least developed countries?
Thank you, Juliet. If you allow me, let me comment on just one or two topics that has been mentioned by my friend Lord Darzi, and also by Nancy and Dr. Kanawi. When you mentioned the ethics, I think the ethics is not only two children, it's the mother. We should not forget. Some of the procedures there are surgeons in this room and they know the technicality. Sometimes we have to do, in rare cases, the surgery just depending on the placenta of the mother, which is called an exit procedure. So the ethics of mother, child, it's a very complex ethics on those. Dr. Ganawi mentioned if they share one organ. Let me tell you, if they share one genitalia, which is especially for boys, this is also technically not easy. And you need a very skilled pediatric urologist who studies them very well to ensure that can we split, for example, the phallus or something. These is taken in the operating room, very difficult decisions. And that's why the surgeons should have also some knowledge about the ethics. Now going about conflict zone, and Nancy mentioned this clearly, Let me give you two programs. For example, earthquake in Syria and Turkey. KS Relief has launched the largest cochlear implant ever for refugees between Turkey and Syria. And it's a world record, just for everybody to know, to do 40 cochlear implant in one day has not happened in civilian circumstances in the best centers. For volunteers to go from Saudi Arabia and to do it in a very difficult situation, this is something that we have also to thank partner NGOs, UN and other players. This is where foreign ministries, diplomats, ambassadors can help. Now going also back to conjoined twins and your answer, I think we have to live in, and now we are living in an era of technology. And those children come from very disabled countries. Now, how can volunteers, this is what I'm suggesting, how could volunteers help those countries? I think we have many women in this room, and my message to them is early diagnosis. There is now ethical changes. We can diagnose conjoined twins as early as 8 to 9 weeks of gestation. And there are many laws that may allow abortion for certain complex, difficult cases. So this is something that I want to put it. How can we allow disabled communities to have an access to early antenatal care, whether it is by remote support or by visiting volunteers or the help of medical international humanitarian NGOs like IMC and others. Now, lastly, I want to also to mention that we should not, conjoined twins is an example of many complex cases, the rare cases that we have in the world. And unless we start coordinating beyond the politics, you mentioned the politics here. Let me tell you with conjoined twins. During the conflict in Yemen, we have brought 3 conjoined twins from Yemen, from Sana'a, from Sa'da, and from Ta'az, during the complete season Ta'az. And this is where the politicians and also UN agencies have coordinated, and we thank them for coordinating that. So such coordination and integration is important, and this forum on this meeting is setting the basis for it. Thank you.
Thank you very much. I think it's fair to say that the whole subject has been incredibly broadened, not just in terms of the medical side of things, but also the political side, the practical difficulties on the ground, and the work that is going on at community level and above. So panel, thank you so much for your contributions. What we're going to do now is to hear a pre-recorded message from UNICEF, in fact, the representative, Her Excellency Catherine Mary Russell of the United Nations Children's Fund. Can we roll the VT, please? Thank you.
It's an honor to join you virtually for this first ever international conference on conjoined twins. I so appreciate the Kingdom of Saudi Arabia's long dedication and work in supporting conjoined twins. UNICEF believes in the power of partnership, and we value the close collaboration with the King Salman Humanitarian Aid and Relief Center. Together, we can create a world where every child, including those with unique and significant needs like conjoined twins, can live healthy, fulfilling lives. Conjoined twins face unique challenges that require inclusive healthcare and educational systems that prioritize equal access. UNICEF is committed to working closely with partners like the KS Relief to create supportive environments where every child can thrive. I appreciate our joint efforts in supporting children with disabilities and their families, including through digital information. This work will offer caregivers and parents critical information and resources to ensure that children with special needs, regardless of their circumstances, are provided with the care and support they need. This platform will not only offer tools, but will be a beacon of hope and empowerment for countless families worldwide. Thank you to KS Relief and to all the incredible participants who are moving this important mission forward. Together, we can help ensure that children everywhere have access to healthcare, education, and opportunities that uphold their rights and dignity. Thank you so much.
Okay, so this is where I stand up. That was Catherine Mary Russell of UNICEF, the United Nations Children's Fund. It is that point in proceedings where we will now take questions from the audience. There are microphones available, so if you wish to put a question to members of our panel, please stand up. In fact, raise your hand. A microphone will be brought to you if you can stand up and also introduce yourself. If you represent an organization, then please name the organization. So would anyone wish to put a question to members of our panel? There's a gentleman over here, from where I am, he's on the third row, the gentleman in the dark suit. Can somebody take a microphone to the gentleman over there, please? His hand is raised. Over here. The chair rows are very long, so there's quite a bit of running that takes place. It's like athleticism. That's fantastic. There's also a gentleman over there, so if we can get the microphone. Ooh, can we have the microphone, please? The gentleman is standing. Thank you very much. Is the microphone on the way? I believe it might be. If not, you're going to have to bellow. You're going to have to frame your hands into a foghorn and shout it out. Fantastic.
Can everyone hear me?
Yes, we can hear you. Thank you. Can you introduce yourself and the organization you represent, please?
So my name is Mohammed, and I'm from Global Impact Consultancy Limited. We're a consultancy that specializes in third-party monitoring and evaluation. I've just got two questions, if I may. The first one, you spoke of lesson sharing. So have there been any medical innovations or discoveries that originated from the unique challenges presented by treating conjoined twins that are now being applied to areas of other medicine? Just a question to the panel. And the second one, working in monitoring and evaluation, what are the monitoring frameworks that are currently in place to evaluate the long-term physical, emotional and psychological outcomes for conjoined twins after medical interventions?
Thank you so much for that. So the first question is lesson sharing, initiatives which have generated great ideas, etc., which in turn have been followed through. Who would like to tackle that one? You're all very shy.
Well, I'll have a go. Obviously, innovation diffused both ways. It's not unidirectional, so it's not going to be from one to the other. I think the world has learned a lot from the innovations under the leadership of Dr. Rabia here in terms of the complexity of this and how you learn the skills to do this. So that's one diffusion of innovation. The reverse would be in other sectors. I think in recent times it's mostly really about imaging, more sophisticated imaging rather than just purely ultrasound, MRIs, reconstruction, to creating models that surgeons could practice on before they embark on operation. If there is a virtual reality platform, for example, you can actually practice many of these procedures. You can even look at the impact of the separation physiologically, if you have a sophisticated computing power, in terms of predicting what the impact would be on a system-based, cardiovascular, respiratory, for example, if that's separation. I think artificial intelligence will come towards this eventually. Obviously, it's helping us with our daily jobs at the moment, but it could even have a huge impact in separation and the accuracy of imaging and the borders, and not to create any collateral damage, per se, as you're doing separations. Fetal endoscopy, so there's plenty of opportunities that we can learn from, but more importantly, the world could learn on from this highly specialized field.
Thank you. Dr. Kanawi, would you like to add to that at all, please?
Yeah, I would like to add that with each surgeries, I think it's being done by the team, we usually involve people from outside our institutions. We bring expertise from different disciplines to join, even at the level of, technical staff or allied health. And that's very important, I think, to expand the skills and competencies, and as well, it will help these surgeons or assistant surgeons or anesthesiologists or anesthesia technicians and respiratory therapists and the rest to help them their practice in other cases. So I think it is as well the complexities and the difficulties of these challenging cases as well will help to build the skills of the different, care providers in other cases. So I think it is essential that we as well not only centralize or make it more national center, but as well introducing at whatever level for each surgeries from the other hospitals nearby you, I think is quite important.
Fantastic. Dr. Arabia.
Well, thank you. Thank you for the question. It's a very good question. The first part of the question, I agree with what has been said. I think digitalization, artificial intelligence is going to change a lot in the future for conjoined twins. And I mentioned earlier, early diagnosis is very, very important. If you diagnose conjoined twins as early as 8 or 9 weeks of gestation, there are a lot of things that you could do much earlier, whether counseling, whether education, whether abortion, you name it. There are a lot of things. Secondly, my friend Lord Darzi mentioned fetal surgery. Fetal surgery or endoscopy can not only diagnose, but can also treat. And this is an emerging also a new era, whether you can reduce one child and block the feeding arteries so that you are left with one twin or the other. This is something is coming. Now, when they are born, again, the era, it's a huge, whether you will do ultrasound, dynamic CT scan, MRI, it depends on the twins. So it's very important to have the experience, the rehearsal. But your second part of the question, which is related to the follow-up, it's very important. I think the follow-up, whether it is on the psychology of children, whether it is in their physical capability, whether in their, what has happened to them. And tomorrow there is a session which I encourage you attend it. That side event is actually about that question and will be attended by one of our twins. They are graduating from university and they will tell you their path from separation till today. I'll stop here.
Thank you very much. Is there anybody else who would like to? This gentleman here, can we give a microphone to this gentleman over here, please? If you could give us your name and the organization you represent, please. Thank you. Is the microphone working? Just tap it.
Working?
Yeah, it is. That's great. We can hear you.
Thank you very much for this arranging international conference. I am Professor Dr. Mohammed Sharif, consultant pediatric surgeon from King Edward Medical University, Lahore, Pakistan, and now recently I joined Qasim Health Cluster. So my question is that we are receiving so many patients of this conjoined twin in Pakistan, and I was in the part of team for successful separation of Amphilopagus at Children's Hospital Lahore in 2008. And now we follow the patient up to the age of 6 years, they were okay. But my question is that these conjoined twins in Pakistan, due to some anesthesia challenges and economical issues, they are being transferred from one hospital to the other hospital. Is there any way to send them to this higher center in Saudi Arabia, where there is a high volume surgery of such twins, so that these twins can be saved? So this is my question to Dr. Rabia, respected health minister. He is one of the authority in separation of conjoined twins. Thank you very much.
Thank you. So it's actually transferring patients in Pakistan to Saudi Arabia.
Yeah, and also the out of cost, because they are economical issues for them. They cannot tolerate the charges.
Okay, Dr. Arabia, and also if Dr. Jan, if you'd also like to contribute, but Dr. Arabia first, please.
Well, if you can start.
Actually, would you like to start that first then, please, Dr. Jan?
I think as far as support from the government and the Foreign Office is required, that will be ensured. And we can liaise with the King Salman Relief Center here for transportation and support to the families. But I'd request His Excellency Dr. Rabia to respond how this can be supported.
Well, thank you, Your Excellency. Well, first of all, welcome my colleague, and happy to have a professor from in the same field from Pakistan. My first immediate answer is yes. First of all, the relationship between the Kingdom of Saudi Arabia and Pakistan is very strong, but Saudi Arabia has opened its program for all children who are unfortunate to be conjoined twins, and they have been accepted by our leaders from all over. We have them from 26 countries, and Pakistan, we have received conjoined twins from Pakistan. You will see them later on today. We have lovely girls who have been separated from Pakistan, and they have come back to meet with you all later on today. So my immediate answer, I think as soon as you diagnose them, please communicate with us. Our foreign ministry is very active, and our ambassador in Pakistan is very active, and the relation between our embassy and the foreign ministry in Pakistan is very strong.
Thank you very much. Now, there's a gentleman here who raised his hand. If we could come to the front row, please, with a microphone. Thank you very much. The gentleman here. Can we have a microphone, please? It's on its way. Please be assured. Here it is. Thank you so much. Thank you.
My name is Hani Najim. I'm a practicing congenital heart surgeon at the Cleveland Clinic. My entire experience with conjoined twin separation is during my tenure at the National Guard Hospital, which is really spanned over 17 years, and I'm so proud to be part of that team. Now, when I was asked to come and speak in this meeting, I did ask many surgeons' colleagues in the United States how many have they done. And compared to the experience that I had at the National Guard, none of them have had any of that experience. So I was privileged to be part of that team. Now, going forward for these conjoined twins, first, I think I do agree with the panelists that there have to be centers of excellence to do this, just like all advanced heart surgeries. And it's not about only taking care of the conjoined twins only. I remember in one of the conjoined twins, just in follow-up of Dr. Kanawi's comment, and I had to do a coronary bypass surgery on the father. I think probably the father is from Oman, he's going to be here. So it's not only taking care of the actual conjoined twins, he happened to be stressed out, had a heart attack, and I had to do the heart surgery on him. Is there any possibility of, now we're talking about transfer of patients, conjoined twins families, that to create an international fund for those patients that can be transferred to centers of excellence? There is no place on earth would have one center would have a large experience. It doesn't matter how busy they are, except that they become a referral center for such patients.
Thank you. So you're talking about having an international fund, basically, so that it's not going to be difficult actually accessing patients, getting them through, if they're connected to these other centers where this type of surgery is carried out, but the fund is the key to it.
Absolutely, and they would be maybe one in each continent where they can do these cases. Otherwise, the outcome is not going to advance so much.
Okay, fantastic. Would the panel like to handle that question, please? The idea, the importance of actually having, please, Dr. Arabia.
Well, Dr. Najim, you are sneaking in our resolutions ahead of us. So I think your suggestion is actually, in one of the discussions in the coming 2 days, is about creating a fund. I think having a center to do them is one issue. We are fortunate in Saudi Arabia that the custodian of the two holy mosques and the Crown Prince have sponsored all of the twins, and we can do them. But also there are expenses that are needed not only for the surgery, but also for the follow-up. And that's why there will be in the resolutions a recommendation to create some sort of a fund. And that's where we are, as humanitarians, we talk about the public-private partnership. We should not all be shouldered by governments. We should think about public-private partnership, donations from businessmen and others. This is something that will be put in the resolutions. Thank you.
We are running out of time, unfortunately. This is clearly one of those subjects which everybody has engaged in. But there was a gentleman here who's raising his phone. Could you stand up, please, and make yourself clear to the microphone operators? Can we bring a microphone, please, to this gentleman? It will have to be the last question, I'm afraid, because time is running very, very tight, but I'm sure that you will be able to address some of the questions to the panel in the later sessions. Is that correct? Yeah, well, fantastic. If it's not correct, then I apologize. Fantastic. So can we bring a microphone, please, to the gentleman who's wearing the brown gilet? If we can get a microphone to him very, very quickly, because time is running very tight, and there is a lot that we have to get through. Thank you so much. That is excellent. And apologies to other members of the audience who wanted to put questions to the panel, but you will be able to talk to them because there are other sessions to follow this one. Thank you very much. So if you could introduce yourself and the organization you represent, please. Thank you.
It's arrived now.
Yeah, well done.
Yes. Assalamu alaikum. My name is Ahmed Al-Muhammad. I'm a legal advisor. I'm the one who's worked with Dr. Rabia in the legal time in this twins congenited. Dr. Rabia, he take care about every small things, even the approved, even the legal issues, and that's we need to, from Dr. Rabia, explain how he take care in the operation and legal issues and ethics. The second thing, last week the International Day for Child, and today we give to all the world this small message. Saudi Arabia giving all the child and all the world the rights of life. Thank you very much.
Okay, Dr. Arabia. So very, very briefly, because we must close, please, thank you. Very, very briefly, please, thank you. The ethics.
Well, thank you, Ahmed, for your question. Well, I think any surgeon, and we have respected surgeons in the audience who deal with conjoined twins, have to have conductivity with the ethical people, legal people, and in countries like Saudi Arabia, religious people. So I remember from the first twin, we have communicated with the religious leaders also, and lawyers and others. But also you have to have a basic knowledge when you operate, because you cannot stop the surgery and say, I want to ask a lawyer. So you have to have that knowledge, and that's where experience is needed. And your question about the rights of life for children, that's absolutely true. You cannot, the surgeons should not be a weapon to kill a child. You should aim to save the life of both twins, unless there are medical conditions that one of them doesn't have the prerequisites of life. And this is where the ethics comes, and this is where the decisions needed by ethical experts, surgeons, and lawyers. Thank you.
Okay, thank you very much for that. I'm sorry that we have to close this now. And in fact, I would actually like to hand the closing remarks, please, to Dr. Arabia, really summarizing the takeaways from this, and above all, the action plan to follow up the initiatives discussed. But very, very briefly, I will hand the floor to you, Dr. Arabia.
I think I talked a lot, but I will be quick because our guest of honor is arriving. Well, actually, first of all, let me thank my colleagues who have participated fully in this session. I think I have learned a lot from them, but I think all of us agree that rare anomalies like conjoined twins is something that needs the attention of the societies. We thank actually the government of Saudi Arabia and the foreign ministry for actually working with the UN, and we thank the United Nations also, and we thank Ambassador Abdulaziz Al-Wasel, Dr. Abdulaziz Al-Wasel, for working with the UN to have a World Day for Conjoined Twins. I think this should be the beginning of continuous collaborations between governments, between United Nations organizations, international NGOs, local and regional NGOs, that they should communicate with leading centers, whether it is like the Saudi National Program for Conjoined Twins, Great Ormond Hospital, and others, and create what we are launching today, a website that will bring registry, research, advocacy, communication, and also awareness for families. This is the takeaway that we should agree on, and we should not forget the well-being and the rights and the ethics of conjoined twins.
Thank you very much, panel. Thank you. Okay, I think that wraps up this part of the session. Of course, there will be other sessions to follow, but thank you so much for your attendance, and above all, thank you so much for those excellent questions. Thank you.
Thank you, Ms. Foster, for facilitating such an insightful discussion. I would also like to extend my heartfelt gratitude to His Excellency Dr. Abdullah Rabia and all of our esteemed panelists for sharing their invaluable perspectives and inspiring us with their leadership and dedication to this cause. We will now take a break as we prepare for the opening ceremony. Please remain seated as we make final arrangements. Thank you.
Just الآن اختبار القناة الإنجليزية. Checking the English channel. Test 1, test 2. Check 1, check 2. Back to Arabic channel.
خلاص الأمير وصل. خليه يقفل يا شيخ وين يروح؟
بسم الله. يصل الآن صاحب السمو الملكي الأمير.
Now His Royal Highness Prince Faisal bin Badr bin Abdulaziz, the Prince of Riyadh region.
السلام الملكي.
The royal anthem.
بسم الله الرحمن الرحيم.
In the name of God, the most merciful, and peace be upon His Prophet, our Prophet, and all his companions. Under the patronage of the custodian of the two holy mosques, King Salman bin Abdulaziz Al Salman, may Allah preserve him, the inauguration of the activity of the International Conference on Joint Twins, and that will be honored by the launching and inauguration His Royal Highness Prince Faisal bin Bandar bin Abdulaziz, the Governor of Riyadh. Your Excellencies, Your Highness, dear honored guests from abroad and inside the kingdom, we extend our sincere thanks at the beginning of this meeting that we will start it with the best.
In Yemen, another agreement with RVD to operate the prosthetics plus and rehabilitation center in Taiz County.
الذي تعرفت عليه حبيب وغالي الله يحفظه
17 سنة
والله ما نسيت الذكريات والله.
كنت أشوفهم بس من خلال التواصل الاجتماعي والآن واجهتهم وجه لوجه.
ما كنت أتوقع أن نجتمع مرة ثانية وأشوف توائم اللي كانوا زي ملتصقين
امبارح كان عيد ميلاده طبعا.
أيوة.
زي امبارح كان تولد.
كم عائلة أسعدت بعد العملية؟ شيء عظيم بصراحة.
ايش تتمنى؟
طموحي المستقبل تاجر.
المفروض إنه ما مر رضا
أكون شيء كبير في المجتمع.
حكومة والشعب نقول جزاهم الله خير.
رسالة أول شيء إلى جلالة الملك
خادم الحرمين الشريفين.
لولي العهد محمد بن سلمان.
والله ما كنت أشوف صفا بهذا العمر كذا لولا الله سبحانه وتعالى والأطباء.
سعادة الدكتور عبد الله الربيع والفريق الطبي.
Thanks Allah. Allah is the greatest because not for him we are not here. Then second things, the doctors and the king.
Because if it wasn't for him, we wouldn't be living a normal life right now.
Można powiedzieć, jesteśmy wdzięczni za to, że właśnie była ta operacja, że wszyscy ci ludzie byli przy niej.
أكثر من كلمة شكر وتقدير واحترام لهم.
هذا بلد الخير. أنا بنات الحمد لله سلامة.
والله جزاهم الله خير. يعني لا لقينا مثلهم ولا نلقي مثلهم.
This was a short movie, a video about the co-joined twins. A group of them is standing in front of you. Memorial photo groups will be taken with the jointed twins and their parents, and this is a historical moment that's an unforgettable moment.
ما زال التوائم وذووهم.
The twins, the co-jointed twins and their parents are honoring the presence here in front of Your Royal Highness for memorial photo. That's one of the historical moments that will be lived by the families, the children and their families after their separation and enjoying a different life. Your Royal Highness, Prince Faisal bin Bandar bin Abdulaziz, Governor of Riyadh Region, please post with these twins and their parents for a memorial photo at this chance. The convention of the International Conference on Co-joined Twins here in Kingdom of Saudi Arabia. And with this memorial photos, His Excellency Dr. Abdullah Al Rabi'a, the members of the conference, and King the members of King Salman for aid to present a plaque for thanks and extending thanks. And with this scene that is gathered, the photos of honoring the patronage, gift of the occasion, families of the twins, and a number of the twins. With this scene, we conclude this meeting that we were so happy. Thank you, Your Royal Highness. Thank you for your prince. And hopefully we will meet you very soon.
الحضور الكرام ننوه بأن هناك جلسات علمية سوف تقام.
We would like to note that the panels will be conducted after this session.
Ladies and gentlemen, the scientific sessions will commence shortly.
الإخوة الحضور نود أن ننوه.
Dear and our guests, we would like to note that after the break, the sessions will be conducted according to the schedule, as it's shown with the program for today. I hope that you go back after the break and please take photos with the twins and their parents.
هذا اللي انا خلاني اجيب سامسونج لما شفت التصوير تبع سامسونج افضل من الايفون. الغيه.
أعزائنا الحضور، أهلا وسهلا بكم جميعا. أعزائنا الحضور،
مشاعل وفاطمة كانوا توأم ملتزم قلب، كانوا بهذه الطريقة عام كم فاطمة ومشاعل كانوا توأم ملتزم. هذه صورتهم الجميلة. كانوا بهذا الشكل في عام 2016. جو للمملكة العربية السعودية وجهت لهم عملية جراحية عليه معالي الدكتور عبد الله الربيعة، واليوم بهذا الجمال ما شاء الله تبارك الله، الله يحفظهم من باكستان. هذا والدهم وهذه والدتهم. ايش القصة؟ عام 2016 صح؟
السلام عليكم.
كلمين صوري بعدين تعال صوري بعدين تعال يلا تعال ايش تبغى تقولي؟ ايش تبغى تقولي؟ قولي اي حاجة هنا عادي.
السلام عليكم.
يلا تعالي 3 2 1 3 2 1 تعالي فيني يلا
شو رقم؟ السلام عليكم. My name is Mashal. I am from Pakistan. Thank you so much, Dr. Abdullah Rabia and Malik Salman and his team. Thank you. مشال ترش.
صوت عالي
Ladies and gentlemen, please take your seats as we prepare for the scientific sessions. Thank you all for being a part of the opening ceremony. Our first session today focuses on multidisciplinary approaches to care for conjoined twins. This session will explore topics such as antenatal care, postnatal support, and the importance of building effective multidisciplinary teams. This session will be chaired by Dr. Mohammed Al-Gattan, Chair of the Scientific Committee and renowned expert in reconstructive surgery, and Professor Oluyinka Olotoye, Chair of Pediatric Surgery at Nationwide Children's USA. Dr. Al-Gattan and Professor Olotoye, the stage is yours.
Assalamu alaikum. We start our first session today. I'm honored to chair the session. I'm Professor Mohammed Kattan, the head of the scientific committee. It gives me great pleasure to introduce the keynote speaker of the first session, His Excellency Dr. Abdullah Al-Rabi'a. He is known to be the advisor at the Royal Court and the Supervisor General for the King Salman Humanitarian Aid and Relief Center. He's also, as we all know, the head of the Saudi Conjoined Twin Program. His Excellency Dr. Al-Rabi'a was appointed as Supervisor General of King Salman Aid and Relief Center in 2015. Prior to this, he has held significant positions in our government of Saudi Arabia, including he was the Minister of Health from 2009 to 2014, the Chief Executive Officer of the National Guard Health Affairs from 2003 to 2009, and also, as we know, the President of King Salman University for Health Sciences for the same period. His Excellency Dr. Rabi'a is an eminent pediatric surgeon and leads the Saudi Conjoined Twin Program as the head of the multidisciplinary team. And as you know, the program is considered a world leader in this field. Welcome to Dr. Al-Rabi'a.
Good afternoon, ladies and gentlemen, and I hope I can have the slides on. So let me take you with a little bit tour on the conjoined twins, and starting with the history. I'm sure a lot of you hear about Siamese twins, and this is actually not the history of Siamese twins. It was actually named Siamese twins because of Chang and Ing Bankar, born in Siam. So Siamese comes from the old name of Thailand. I hope the slides come back again. And those twins actually moved to USA in 1829, and they were actually at that time circus players and very famous. The history claims that they have married 2 sisters and they fathered 22 children. And now the history of surgery is actually, again, lots of stories, but the first attempted separation was as early as 1495 when a craniopagus twins, one of them died, so they decided to take an axe and tried to chop one twin from the other. Both of them died at the same time. The first clever Siamese twins successful separation was by Johannes Fatio back in 1689 by using a constricting band for a set of Omphalophagus, presumably it is a small joining in the skin, probably a little bit of the liver. And the first successful separation for craniopagus sets did not happen till 1957 by Voris. Now, let's talk about a little bit about statistics. In Western countries, it's been estimated that we get one conjoined twins in every 50 to 200,000 births. However, it is more in Southeast Asia and Africa, presumably because identical twinning and twinning is more in dark-skinned people in Africa and also in Southeast Asia, increasing the incidence. And actually, 60% of conjoined twins are stillborn, and those who live, 40% of them will die in the first few days of life, and those who live, 70% of them will be females. Well, just for those who are actually, the diagrams for the non-surgical teams or the audience, so those who are joined in the chest are called thoracopagus, and they probably in the incidence is the highest, and then craniopagus is probably lower, although in our experience, craniopagus is much higher than 1.5%. And when they are joined in the abdomen, it's called omphalopagus. And again, in our experience, it's much higher than 0.5%. And when they are attached on the gluteal region or the back, it's called pyopagus, and it's about 18%. And if they are joined at the pelvis, it's called ischiopagus, and that's around 6%. And to make it even more difficult for non-pediatric surgeons, if they have 2 legs, it's called bibus. If they have 3 lower extremities together, it's called the tribus. And if they have 4 lower extremities, it's called tetrabus. So the name is going to be long. You can say thoraco, omphalo, ischiopagus, tribus, or tetrabus. And those twins are monozygotic and actually monochorionic of the same sex and chromosomes. So basically for non-medical people, they are identical twins. They have the same genes, the same genetics, and like identical twins that we see in life. Again, we can make it even more difficult. If there is a part of a body on a body, it is called abdominal heteropagus. If there is lower part of the body duplicated, it's called caudal duplication. If there is a part of a head joined to another head, it's called craniopagus parasiticus. And if there is parts of a twin inside a twin, it's called fetus in fetu. And I usually question people. They say, can a boy get pregnant? Well, in this concept, yes, but it is actually a kind of heterotoma. Now, what are the causes of conjoined twins? I'm sure we have a lot of women. What are the causes? Give you like a quick answer, nobody knows. And the most accepted theory is the incomplete division or the fission theory. Basically, it is an identical twins early in pregnancy, which does not get complete separation, because identical twins are one body when pregnancy starts, and usually by 2 to 3 weeks, the separation starts and ends by the 4th week of gestation. However, most researchers think there are some deficiency of division regulators, probably prostaglandins. Still, there is a lot of research in this area. And again, the diagnosis, the better diagnosis nowadays is as early as 8 to 9 weeks of gestation, and that's why we believe on the use of antenatal ultrasound, antenatal echocardiography, and sometimes you may require the utilization of MRI. However, after delivery, it depends on which kind of twins you are dealing with, and it depends whether you need routine X-rays. But however, we have found, my colleagues and I, we have found the best actually is to start with the multi-slice dynamic CT scan, and then you have to go to based on the sharing and detailed investigation. Now, I must stress on those 4 things, which my colleagues and I have learned over the last 35 years. The importance of multidisciplinary team cannot be overemphasized. Detailed thorough, careful investigations cannot be overemphasized. Informed consent, the involvement of parents is important. Written operative plan, we write the operative plan and who goes in and who goes out and which part ahead of surgery. And of course, rehearsal. And in our experience from 1990 to 2024, it is a one-team experience, which is very rare in many centers to have one team experience. Usually it is one team and second team and third team. In ours, we are lucky that it's one team, and if you speak to anyone of the team, they have seen 40, 50, or 60 sets, and this is what make this center is unique. We have seen 143 sets from 26 countries. Unfortunately, only 85 of the sets have an antenatal diagnosis. And again, unfortunately, only 95 sets had cesarean section. Some stories are actually alarming. Some of them came from actually fragile health systems or primitive or rural areas where actually there has been birth trauma to the mother, and also the delivery was not as easy as we can imagine. These are the twins and these are the countries, most of them from Saudi Arabia. As you can see, Sudan, Yemen, Egypt, and you take it, 26 countries. And again, we have separated till today 61 sets, and we have 7 sets waiting for separation. I was talking to some of our colleagues from Great Ormond Hospital. Normally you have waiting lists for hernias, for gallbladders, for others, but to have 7 sets waiting for surgery is actually rare to have. And again, this is how our percentages goes, and I thank Dr. Namshan for revising this recently. 15 of them are thoracopagus, 34 are thoracoomphalopagus, and 17 thoracoomphaloesophagus, and 2 are the cephalothoracoomphalopagus, and of course the dyspropus and parapagus are actually 1 and 7, and omphalophagus 21, ischiopagus 19, and craniopagus 10. So we are higher in some of the cases than others, and lower in the pyopagus, and we have parasitic twins. Now, these are the cases that we're waiting for surgery from Eritrea, Asma and Sumaya, and we have also Hasna and Hasina are waiting from Nigeria. We have also from Pakistan, which is we are not allowed to show the pictures based on the request of the parents. We have also refugees from Syria trying to come to us and under process, Eileen and Celine. We have also Filipino twins and on the way to be here. And also we have from Burkina Faso, as you can imagine, waiting for surgery, and from Mauritania also waiting for surgery. So these are the cases. The upcoming slides, I will go through them quickly for the sake of the time. I have colleagues who are going to lecture after me. So this is the first set, simple case, 1990, only a part of liver and skin, which was only 2.5-hour surgery with a success. And then this is the first actually, and the girls were here in the chairs before we started, Samah and Hiba, an 18.5-hour surgery with a success. And you'll see them as we go in the conference. And then we have another abdominal heteropagus, and also we have another xiphoomphaloesophagus tribus, and this is also craniopagus parasiticus, and you take it from on and on. This is actually a unique case. This is a triplet pregnancy, and one of them were actually as you can see, 1 child was normal and 2 were actually joined, and they were successfully separated by my colleagues and myself. This is another complex case, came from Malaysia, went to London, and then ended to Riyadh. This is one of the longest surgeries. It took 23.5 surgeries because of a previous attempted surgery, and it required a delicate surgery, and the twins actually are here this morning. They took a picture with the team. And I'll go again from Egypt, another set, and another set also from Philippines, which you have seen them in the video, and they're here today. This is actually also very interesting set. One of the twins has actually cystic adenomatoid malformation in the lung. So it is a surgical decision making is to do surgery on one of the twins, remove the middle lobe, the right middle lobe to avoid complication, and then continued with the separation, which lasted for 18 and a half hour surgery. And this is from Poland, also another a case with a success, and the beautiful girls are here in Riyadh now. And again from Egypt, Morocco, and Iraq, and also from the Cameroon twins, and also from Saudi twins, and also another caudal duplication case, and also from Oman, craniopagus, and the twins are here. You have seen them actually around today with another stories of success, and also another Moroccan twins, and also from Iraq, Egypt, and Somalia. This case is fascinating. One twin actually did not have the prerequisite of life and depended on the other to live. And after all ethical considerations, we have done an exit procedure, and the separation was done, and we have benefited from the placenta to help us to do rapid separation and salvage the life of the viable twin. And another set from Morocco, and also from Bahrain, another also exit procedure, because one twin you can see clearly for those who are on the medical side, the blue twins on the right side of the picture. And then we have utilized the exit procedure on those twins, and another also set of parasitic twins, and another also caudal duplication from Jordan, from Iraq, from Algeria, and also from Saudi Arabia, and also Iraq. And also from Saudi Arabia, the parents refused to have media or photography for those twins. And also from Sudan, and also from Yemen, and also from Egypt, and also from Yemen, and also from Yemen, another caudal duplication, and also from Syria, another craniopagus case, which you have seen them today in the around the conference. And also from Pakistan, you have seen the beautiful girls from Pakistan, which were separated also in 2015. And also another set of Saudi twins, Sudanese twins, and Yemeni twins, and another one's from Sudan, from Palestine. This case actually is interesting. They came from Gaza Strip, so that's where the UN is important. UNICEF helped the transport. We have to bring the twins to Riyadh and then do the separation. Another also twins from Saudi Arabia, from Tanzania, and from Libya, and also from Saudi Arabia, from Yemen, and Saudi Arabia, and Iraq, and Yemen, and Nigeria, and Egypt, and also from Syria, and also from Tanzania, and Nigerian twins, and the last from Philippines, which is also they are here around us. So let me go to the more technical. What we have learned, my colleagues and myself, we have learned over the years, you should try to minimize the blood loss. It's very important. Now with the new technology, probably in most twins, you will not need blood transfusion. You have to be careful and delicate, and you will not need. So the careful surgery, the utilization of cavitron, CUSA, or argo laser, or focus in the diaphragm will help reduce the blood loss. And also the improvement in anesthesia. And my colleagues, Dr. Nizar Zghaib and his team, have actually been doing great in the anesthesia. And we have now managed to awaken conjoined twins at the end of surgery. The last Filipino twins, we came up carrying the twins, and they are actually awake, and their parents carried them by their hands at the end of surgery. Another thing, what do we need to do after surgery? So you need continuous team approach. I cannot overemphasize the importance of team approach. This is a procedure which needs a full team approach. And it's important from admission till actually the last day of their life. This is important, whether it is surgeons, doctors, nurses, all specialties have to coordinate. Also, the involvement of psychologists and psychiatrists to help in the separation trauma. We have seen it in the Malaysian twins. They are, when we separated them, they are around at the end of their 5 years of age. So when we separated them, we noticed there is a tachycardia which is unexplained in the twins. So when you brought them together and they touched the hands of each other, their tachycardia was cured just by physical contact of them. And also the rehabilitation and physiotherapy is important, and long-term follow-up is extremely important. And I was happy to see the signing of an international NGO today to ensure that you can reach children with remote areas. You have seen some of the twins need a prosthetics because they are in a remote area in Africa, and for them to come and then we will have somebody to help us in their prosthetics is something which is important. Again, where do we go next? And then, as I mentioned earlier, the early diagnosis will help us. Do we go for abortion if there is a risk on the mother, on the children? Do we go for fetal surgery, which is also, and Dr. Saud Shneif is here, who is an expert in fetal surgery, and this is an area that we have to think. And we should not forget the importance of the exit procedure should there will be risk on the life of those children. Now, I will not bother you a lot because of the sake of the time, but abortion is approved in many countries, provided that you adhere with the guidelines of abortion that follows either religious or ethical or legal guidelines in each country. Now, fetal intervention is also, some of the research on thermocoagulation has gone way good to reduce one child who is actually endangering the life of the other twin. And I have talked already about exit procedure. Now, conjoined twins in triplet pregnancy, it's very rare, but we have seen 2 sets and their outcome was great. So it is important that although it's rare, but normally you may have an outcome which is good. And if they are not very complex cases, we would suggest to continue the pregnancy and proceed with the surgery. Also, we should not forget about those cases which are rare. These are actually, the name is wrong. This is triplet conjoined twins. So you have 3 sets, but none of them will be born alive. And those are kind of twins which are only for publication and academia. And what we have learned about our experience, at least in Saudi Arabia, our religion teaches us to have peace and love and help for those who are in need. We respect the compassionate care of the leaders of our government, and also the humanity logo of Saudi Arabia and the vision of our leadership. I cannot actually leave you without recognizing the custodian of the 2 holy mosques, His Majesty King Salman bin Abdul Aziz, and also our beloved Crown Prince, Prince Mohammed bin Salman bin Abdul Aziz. They have supported the team, they have supported the program, and they have sponsored the twins till today, and they continue. We have not sent a request for bringing a twin that has received a rejection. All of our requests have received full support, including financial support for the twins. And these are the twins. I'm sure we have a better picture today. We will put it. This is actually the group picture for our twins. Our actually colleague designer Baria has put it for you in black and white, and we appreciate this picture. And I cannot again leave without recognizing my colleagues, the multidisciplinary team, for their hard work, dedication, major input, and distinguished team approach. This is only examples of many colleagues who have done hard work over the last 35 years. And let me say thank you, thank you, thank you. And for those who are outside the kingdom, this is Saudi Arabia few decades ago. We have only mud houses, and medicine is primitive. We have moved till today the era of AI and also modernization. And let me conclude by a short recommendations. These conjoined twins are rare anomalies, and you need careful and thorough investigations which are highly needed. Again, the importance of multidisciplinary team approach is very important. We feel that the need of tissue expanders and prosthetic meshes only needed in selected cases. If you read the literature, there have been an overuse of tissue expanders and prosthetics. You have to be selective. In certain cases, of course, you need them, but in the majority of cases, you will be able to do flabs and others, and you can be able to do primary coverage. And my last recommendation is that early diagnosis with the potential of aborting selected cases not compatible with life may be considered once ethical and religious aspects are covered. And my time is over. Thank you for yours. I took this actually from Ziggy Ein. He always says, my time is over. Thank you for yours. Thank you.
Thank you for that very excellent presentation.
نشكرك صاحب المعالي. الآن ننتقل إلى المتحدث التالي دكتور سعود الشنيفي، وهو أخصائي أطفال، ولقد قاد برنامج الرعاية الطبية بمستشفى الملك فيصل التخصصي ومركز الأبحاث الخاص بالمستشفى في الرياض. ودكتور الشنيفي
Assalamu alaikum. Good afternoon. It's always easy to follow Dr. Rabi'a, so anything that you want, I gather from here you already got it. I think the success of this presentation depends on many factors. I just want to ask, do we have a true embryologist? Good, so it's going to be successful, since I'll be the only one. Anyways, probably you know that we have published a chapter recently in one of the new books, fetal and neonatal surgery and medicine. And of course, we gathered it from the vast experience of Dr. Rabi'a. And part of it was the embryology. And I have to say that we did not dig much, because in a chapter in a book, in a clinical book, you want to really go in depth. But preparing for this presentation was really challenging, because as you probably have seen, Dr. Rabi'a mentioned the agreed upon is the fission theory, while there is the fusion one. And it's actually, when you dig into those articles, it's really very challenging to come with one way or another, and you will understand. So we're going to go over some general facts, most of them covered by Dr. Rabi'a. We're going to talk about the embryological theories, and we'll talk about a few implications of the embryology. I'm a pediatric surgeon by training, so embryology is a major part of our practice, because we deal with a lot of congenital anomalies, and without knowing the embryological basis of it, we may not be able to choose the right surgical approach. So it's rare. Twinning in general is rare. 187, that's in general, but most of it is the dizygotic, where you have 2 zygotes and 2 sperms. The monozygotic stable incidence, 3 in 1,000, and the conjoined twins is even a rare part of that, which is in the vicinity of 1 in 50,000 to 200,000 in some populations. Triplets, again, is rare. Quadruplets is very rare. And in one review in 2011 about conjoined twins, 46% only lived to birth. The rest were stillbirth, or the pregnancy was termination. And termination here is very important, because it really affects the real incidence. That's why you can't really tell what's the real incidence for this anomaly in the population. As we said, 40 to 6% stillbirth. Gender is mostly females from the live births, but if you include all, including the terminated ones and the stillbirth, males are more. Legalization of termination affected the incidence of conjoined twins. Different species reported to have the same, with almost the same embryological guides, but we could not really get into it because of the experimental model does not really exist. A few case reports for triplets and quadruplets. The viviparity and oviparity are the same, means babies who are born outside or develop outside the womb, which is like the eggs, are the same like the ones for the viviparity. It is considered a fascinating phenomena, as you know. Historically, the interest based on societal beliefs, they used to call them double monsters in scientific literature. At one stage, they were considered a curse. They became even a circus material, and then it really holds a high emotional component. Lately, the separation became possible, and interest is mainly focused on separation. As Dr. Rabia mentioned, El Fatio mentioned it, it was reported in a book first, but the reports were around the 1600s. Baldwin in 1956 did the first one, Coop did the successful one in 57. So if you really can follow these, the dizygotic is the one on the left where you start with two ovaries fertilized by two different sperms. But the ones in the green, which is the monochorionic twin pregnancies, you will really look at the one with the monoamniotic, and small part of that, you will end up with the conjoined twins sharing one amniotic cavity and sharing one placenta. There are 9 types, and it's, I think, more. Dr. Rabia mentioned that. It depends on the site of the attachment. Terminology already shown. It depends on the attachment and the number of the limbs available and the anatomical structures involved. And this is just for, a quick cartoon to show you that. So it can be identified as early as the 2nd trimester. Could be done earlier, but it's really difficult. No separation membranes at the beginning, inability to separate twins' bodies, and constant head position make you suspicious that there could be twins are conjoined. Evaluation by ultrasound, MRI, or fetal echogram, usually born by C-section to avoid any problem during the pregnancy. Separation has increased over the years, hence embryology was studied extensively. Diagnosis was made, so people went back. Termination now is an important aspect of the management during the pregnancy, and the separation techniques evolved over the years. And this is just a simple normal development where an egg is fertilized, zygote, and you come to 2-cell, 4-cell, then 8 to 12 to 16, where the morola is formed, then the blastocyst with the pellucida around it. Again, this is when you look at the zygotic, they go separately, they get transplanted in the uterus, but the one with the identical one goes as one piece, and this has some more details to it. So God knows when are they gonna separate, and that's what really gonna dictate what type of conjoined twins you will have. I will just show you this one because this is really very clear. You start from the zona pellucida around the morola, so 1 to 3 days you will get that mass, and 30–40% will be dichorionic and diamniotic. While if you go with the cleavage later, 4 to 8 days, and the blastocyst will divide at that point, you will end up with the monochorionic and diamniotic. That's 60% to 70% of the monozygotics. If the cleavage goes beyond, we're talking about 8 to 13 days or beyond that, that's where you have the 2 fetuses or 2 embryos in one sac, and that's where the conjoined twins could occur. And you can see now that the 2 theories, fission and fusion, compete. And the last one to show which one is really happening. Is it like they don't separate, or they separate and they fuse again? The factors that affect the monozygotic twinning on the left side, people thought about the mechanical one. This is all experimental, by the way. But then some twinning stimuli have been noticed, like ethanol, urethane, vincristine, vinblastin, hyperthermia, and some medications that are not really teratogenic, but still they could lead to the development of the conjoined twins. So only 3rd and 4th week after fertilization are pertinent to the development of the conjoined twins. That's where you have a rapid growth with different rate, change in size, shape, and relative position of structures. The flat disc here is very important to see, and summarize this presentation that's not really well understood, to be honest. Experimental embryology is not really well developed. Some mouse models, some triton, which is type of snails, but still they could develop it, but it's not really clear how did it develop. In humans, I think they rely on the hypothesis construction by reasoning backwards from observed anatomy of late stages. So they just predicted backward what happened. So now, fission or fusion, basically, do they separate first as monoamniotic or monozygotic, then fuse again, or they never separated where the fission theory dictate? This is just a simple diagram that I made just to make it really clear. If you look at this zygote now, fertilized, on the left side, it separates. That's the normal fission, where you have the two monozygotic twins. But then again, at different or later stage, they start fusing, and we're going to talk about that in details. Or you start from the get-go, that the zygote itself form the embryonic disc, then from there you start the fission, which is not complete, meaning they divide, but they still are attached at certain areas. So for the fusion theory, it says two embryos unite at one stage at specific site to yield conjoined twins. Aristotle have mentioned because they live in the same sac. I don't know if he meant that they live in one amnion, or he just said it at that time, thinking that this should be the way to go. Kaufman in 1916 talked about the coalescence of the two primitive streaks, and in 1895, Marquand said the secondary union of the open neural tubes, and that's very important because he's talking about open areas on the embryo discs, because if there is an intact ectoderm, there will be no fusion. One dizygotic twin was reported conjoined, and that really made people really very confused, because the dizygotic, they shouldn't be really conjoined. So if two dizygotic with two different DNAs joined, means that opens it for the fusion theory more than the fission. Mirror imaging, that's when you have situs inversus for the babies. We're going to talk about it later. There is a review of 1,200 cases, and the questions were, why consistent attachments? And that really led the embryologist to think that it has to be in absent ectoderm areas. Why inaccessible areas in early embryos can join? Because inaccessible ones become accessible later. Why some has single and some has double umbilicus? Ventrally joined ones have one umbilicus, dorsally ones they have two. So they came up with these explanations with time. And this is just to show you a simple way of how things are changing in the embryo. If you pay attention to these membranes, the cloacal one or the oropharyngeal one, these are the most that really joins. And if you can see them now, they really convolute around the yolk sac, and you end up with the heart primordium on the ventral aspect of the baby. At those times are where the two embryos can join. And this is just to go for the classification, ventral ones and the dorsal ones. You can see them from the pictures. And I see that the fusion theory has more to say about the process rather than the fission, despite the fact that some people believe that the fission one is the go. So here, just think of it as embryonic discs around a yolk sac, and they start joining. If they join head to head or side to side, that's where you get these sets of conjoined twins. Now, if you reverse it now and stay on the out, where the yolk sac is out and the amniotic cavity is inside, you end up with the dorsal ones. So again, this is under the fusion spherical theory. So the spherical theory explains all 8 types: invariable duplication of the umbilicus and umbilical cord in the dorsally ones, and less frequent in the ventral ones. Unions occur where the ectoderm is not intact, and dorsal conjoined twins explained easily with fusion, and fission is difficult to visualize for those set of twins. And this is just again to show you how when you have the division and diversion of the mid-sagittal structure. It's very important when they are really joining the structures, they don't really vision that way. They really have to do some rotational movement, and you will have an anterior and posterior. The one's anterior belongs, half of it belongs to one of them, the posterior ones belongs to another one. And this makes it really difficult in imagining how they all fit, and that will affect the way you incise in order to separate them. Shared organs is also another issue. One side broader than the other. This makes it difficult to understand where is the anterior, where is the posterior, so they do some measurements. If they are symmetrical, it's easy, but it will be difficult to say which is anterior, which is not. So they rely on the heart and the umbilicus to judge that this is anterior or posterior. Ventral union affects umbilical status. All share an umbilicus. Cleft lip and palate mostly with the cephalopagus and parapagus. The ventral conjoined twins are united rostrally, caudally, or laterally. These are the ventral ones, and the site extent depends on how the heart primordium has rotated and has joined. This is a very important concept in the conjoined twin, the anatomical adjustment of after the fusion. Because when they fuse, you really have to find a way to dissipate those organs. How are they going to move? I mentioned to you how they rotate, and some of them goes half go anterior, half go posterior, but that goes also for the symmetrical ones. They go with the conjoined heart, they go with the single falciform, and they go with the umbilicus to the side. Right and left, anterior designation, twins can be called right or left. If no definite criteria, the smaller twin is considered on the right side. The umbilicus, as we mentioned, the ventral ones, they share it. The dorsal ones, they have different ones. And the heart, this is just to give you a diagram how the heart is considered. They may have two shared hearts, one compound heart, two separate hearts, or one compound heart, or normal. And this is very important in decision whether to do it or not to do it. And if you're going to do it, you really have to approach the heart from the right angle. This is also the other associations with other vascular anomalies that goes with it. The GI, usually in the cephalopagus rostral half of the GI sharing. The thoraco and omphalo-distal foregut is usually shared. Ischiophagus, caudal half of the GI tract. The parapagus, it depends. If it's the dicephalus, the caudal half, while if it's the diprosperous, this is the entire tract. The liver usually united in all the cephalo, most thoraco, many omphalo, and few issue, and all the parapagus. Urogenital side usually not involved in the dorsal or rostral, but the parapagus and diporous and ischiophagus, they may have single or shared system, and that's also could be a challenge during the separation. The parasitic twins, usually they're considered parts that are vascularized by the main twin, and mostly with the omphalopagus and the ischiophagus. Again, this one is very difficult to relate to the fusion or fission. The fission, as I said, it's late splitting of the single embryonic axis into two axes. It's incomplete, give rise to one of the various types. One twin may not have a heart, and the fetus, as mentioned by Dr. Rabia, is one of the things that considered maybe the fission, and we consider it in pediatric surgery sometimes as a teratoma rather than a conjoined twin. Mirror imaging, more in conjoined twins, hence supportive of the vision theory. Rotation of the heart initiates the embryo's process of lateralization. That's why the heart is very important to decide on right, left, and anterior and posterior. The molecular and genetic factors is really primitive. There are some signaling molecules that play a role in early embryogenesis, but none of them have been really correlated with conjoined twins. Specifically, left to right asymmetries during embryogenesis is not yet elucidated. I think the implications for the embryology here is important in counseling. Some may need separation at birth, as mentioned by Dr. Rabia, where the exit is needed. Termination, 60% are stillborn, and they may add to that with the termination if it's a choice for the family. Planned separation of surgery could benefit from embryological baseline of the congenital anomaly itself. Timing and goals of surgery too, related to the embryology. And putting this all together may improve the survival of these babies when considered during the separation. Thank you so much, and sorry if it was really boring. We
now introduce the third speaker, Dr. Mohammed Namshan. He's a pediatric surgery consultant at King Abdullah Specialist Children's Hospital at the Ministry of National Guard. His topic is very, very important. It is the building the multidisciplinary team.
Assalamu alaikum, Mr. Chairman, Co-Chairman, ladies and gentlemen. Now what we'll discuss in the next probably 10 to 15 minutes is something that have been emphasized in the morning. It is the key point of the successful surgery and successful management of those conjoined twins. And that is the multidisciplinary team approach. So I have nothing to disclose. The multidisciplinary team approach is defined as collaborative practical model where the professional from diverse fields work together towards a common goal to improve the outcome. The approach involves integration of knowledge, methodology, and perspective from multiple disciplines to address a complex problems. The concept of the multiple MDT approach have been gained prominence in various fields, including education, healthcare, and research. The MDT concept is not new. It can be traced back into the ancient civilization, where Aristotle, who is one of the sciences that Dr. Saud mentioned, and even has a theory in embryology, and Plato reflected an early understanding of the collaboration of various fields such as philosophy, science, and ethics. By the integration of those sciences with each other and joining the expert from the various specialties give the first foundation of the high education at that time. However, it's not until the last century when the MDT began to gain traction multiplically in the context of education, research, and healthcare. In the medical field, the MDT can be traced after the World War II, where establishment of the MDT teams became essential to address the complex need of the returning soldiers. Then, after that, the emergence of the health specialties in the medical care, like oncology, transplant, cardiology, neuroscience, necessitate the specialists to work together to give a comprehensive care. According to the WHO, the MDT in the clinical field is a group of health professionals from various specialties who work together to provide coordinated care. This collaboration improves the clinical outcome as well as the patient and the staff satisfaction, while the error and rate of the length of stay and the cost get reduced. Individual approach, when one person approach a complex health issues like the conjoined twins, will result in many things: fragmented care, longer time to provide, more expensive, and even worse outcome. Why we need the MDT approach? Because it enhances communication, because each individual in the team will be informed about the care of the plan, and that will improve the flow of the patient care. It is comprehensive, where the MDT address all the medical need of the conjoined twins. It's also address other needs like the social, psychological, emotional, financial, and all the persons who's looking after these require or needs of the twins should work with each other to coordinate their care. Increase efficiency. The collaboration of the various specialty can lead to more efficient use of the resources, avoid the duplication, and also reduce the cost and improve the outcome as well. The multidisciplinary approach in the Conjoined twins is one of the key points that lead to successful care of those complex, challenging cases. And their care start during even the pregnancy, when you care about them and about their mother, then after delivery, and the surgery is not the end of their care. It's actually starting another journey of their medical care. We look at them individually rather than looking at them as joined that really require medical treatment, psychological, social, physiotherapy, rehabilitation, till we integrate them in the society or the community. The MDT personnel that involved in the conjoined twins, really we cannot count them probably in one slide. And that depends on the, have been described in the previous lecture by Dr. Rabia and Dr. Shinafi in the area that they are sharing. That will dictate which specialty that you need. But most of the time, caring of them is challenging also during the pregnancy, so you need really specialized people that they will look after the mother and after them antenatally. Then after birth, they will require many specialties from the pediatric side, the pediatric complex team, and the other pediatric specialties, including cardiology, infectious disease, and other services that is needed. Surgeons from various specialty, they are depend on the joining area, will dictate the which specialty from the surgery that they will join the team. Usually they are pediatric surgery, plastic surgery, orthopedic, urology, neurosurgery, and others if they are needed. Those babies who are caring about them, they will require multiple visits and to the radiology department and the OR, and when are doing most of the invasive procedure, they require anesthesia. And the anesthesia is very challenging on them, as will be discussed tomorrow in the lectures, because we are dealing with unique positions, unique physiology, and unique transferring of the drugs between them. Radiology and advancement in the radiology in the last few years helped a lot in the progression and advancement of the separation of the conjoined twins. Intensive care unit in the neonatal and the PICU, nursing staff, and other supportive paramedical area from dietitian, physical therapist, and social workers. Ethical and legal advisors, as we heard from Dr. Rabia, they are very important, and there will be a session today to discuss these issues. Also, the integration of the medical care with the other supportive care that comes from the community and from the humanitarian and charity organization is very helpful, and we need to integrate them in the care of those complex medical cases. Effective coordination of this team is essential for the success of the MDT team. So a team leader is designed, and he will be responsible for overseeing the team activities and facilitate the communication to ensure that all aspects of the care have been addressed in the right time. Developing of the clinical pathways is an important to avoid the variation on the care of those patients, where by changing of the individual and also by changing of the team, the flow of the work and the care will be standard. And this is just a screenshot from one of the clinical pathway that was developed by our pediatric complex team to look after those conjoined twins. The working in MDT with very coordinated work is in the operating room is very, very critical because you have many people in limited time and in limited space. So as Dr. Rabia mentioned in the morning, that the OR, we should clear about it and we write the phases of the surgery. And in the previous meeting, we planned the surgery and put the phases. In the OR, we do a rehearsal. What is a rehearsal? We bring the twins a day or a few days before the OR, before the surgery date. We bring them to the OR because they are unique asset. We are something that we are not used to it in our routine work. And to put the demographic of and the ergometry of the OR, where will be the anesthesia machine, where will be twin A, where will be twin A, where is the surgeon will stand, where the assistant will stand, where is the back table, where is the myo stand, where we will put the second twin when we move him. All this should be planned and written prior to the surgery. When you start to get similar sets and you get an experience, we just plan it and we don't do the physical rehearsal. And probably in the last 10 years, we did only probably 1 or 2 rehearsal. The MDT during the surgery, and we mentioned to control the face or the flow of the surgeons in the OR and to decrease the traffics, we need a written plan of the surgery with the names, and the team leader usually in the OR will see the stages and will coordinate the care. The advancement in the virtual software and in the telemedicine give the healthcare providers really an opportunity to discuss the complex care for the patients without meeting physically. And this was very obvious in the last pandemic, where the physical meeting were, for example, like restricted. So the utilization of the digital tool was utilized really in a very efficient way and give excellent results, even in the conjoined separation and in other fields of medicine. And I think they should be used also to coordinate the care of those twins as we put them patient-centered inside like the countries or national or even internationally. One of the threats of the expert multi-MDT is when the expert people leave the team. So to have sustainable team and the care of those patients will remain, we should plan the replacement of the people that they are leaving the team due to retirement or philanthropy by introducing new people in the team gradually ahead of time, so they will get the experience and they will replace their expert colleagues when they leave. Summary, MDT approach represents a vital shift in the management of the complex health condition, and management of the conjoined twins is a complex journey that necessitates the presence of robust MDT approach. MDT model is not enhancing the quality of the medical care, it also enhances the outcome and address the psychological, social, and emotional needs of those twins. The use of the digital tools in the virtual approach will enhance collaboration, improve access to the information, and increase the workflow efficiency. That's my references, and thank you.
All right, moving right along. It's my pleasure to introduce our next speaker, Dr. Nadia Al-Gilan. Dr. Al-Gilan is the Division Head of Maternal Fetal Medicine at the Ministry of National Guard Health Affairs in Riyadh. And she'll be talking to us about a very important topic here with conjoined twins, that's the antenatal care and labor. Dr. Al-Gilan.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Peace be upon him.
Scientific and Organizing Committee for this first of its time, the conference about conjoined twin. And I don't know, shall I say it will be much more easier for me to present after very distinguished speakers, His Excellency and the other two speakers that they had already their presentation. So I'll try to go over the prenatal journey for a conjoined twin from an MFM or obstetrician point of view. So in generally, just to look at caring for those kind of special situation is a very complex and delicate process. It requires definitely a meticulous prenatal planning for pregnant patients caring for conjoined twin, and definitely will need a dedicated medical team before, during, and after delivery. The journey, usually it's filled with the unique challenges, ethical consideration, and utmost care to ensure the best possible outcome for the twins and their family. And this is very much like mentioned by previous speaker about the MDT team and the ethical part of it also. Now, to understand the prevalence, some of these already had been mentioned by my previous distinguished speakers about the prevalence or the incidence, and probably, as mentioned, it can be 1 in 50,000 or sometimes 1 in 200,000 live births, making it an exceptionally rare phenomenon. The number could be higher, and this is owing to an earlier miscarriages or termination. The female to male ratio for the delivered one is, as mentioned, 3:1, and only 18% of those conjoined twin usually will survive to the infant time, and most of them, they might end with early neonatal death up to 35% to 40%. To understand, I'm not going to go on the detail. Dr. Saud al-Shnafi already mentioned the theory behind why it's happening, either fusion or diffusion. So I'm going to skip this part because it had been already mentioned. His Excellency Dr. Rabia already talked about the type of conjoined twin and already addressed also by other speakers, so I'm not going to have more time. The same, I think, the information and the cartoon shown already to you earlier. Now let us talk about the prenatal diagnosis, and I think this is where MFM or obstetric came along as part of the team. So it had been reported by an ultrasound diagnosis of conjoined twin as early as 1976 by Wilson et al. And the diagnosis usually often made between 10 and 14 weeks of gestation, hopefully that those patients or those pregnant mothers will come for the antenatal care earlier. However, in other studies, they reported that it can be diagnosed between and 20 weeks, and we think that this is probably a bit late in developed countries, maybe in more developing countries, or even, as mentioned earlier, sometimes occurs as sudden off during labor. For sure, the early diagnosis of this condition will give the time for a prenatal referral and counseling, planning of delivery, and the postnatal care. And this is very important to be mentioned to the frontliners, primary health care, early ultrasound placement for first trimester. For those patients will give the early diagnosis, appropriate referral to tertiary hospital. So in ultrasound, in the first trimester, it's early usually detected, as I mentioned, if it had been done between 10 and 14 weeks. And usually twin gestation with a single yolk sac, in seeing a twin with only single yolk sac will raise the suspicion, should raise the suspicion, I would say, to the attending physician. Or if you see there is no intertwining membrane that indicate a monoamniotic, and with very occasional, body movement of the whole solid of the twins together, it gives the hint for a possible conjoined twin. Later in gestation, very important, the role of ultrasound to determine the shared organ and the shared visceral involvement, and if there is any cardiac structural anomalies, and the impact, that will impact the counseling. Radiological aid also in the diagnosis, and there is a big role for MRI, and our colleague in radiology department play a very excellent role and will usually map the twins even much more far better along with the ultrasound. The other thing that's very important is having a fetal echo done early enough to decide if these twins shared a major vascular cardiac or non-cardiac, and this is also very helpful in determining later on for the separation. Later on, once initial diagnosis had been put and confirmed, a genetic testing by means of amniocentesis or chorionic villus sampling to make sure that there is no trisomy or other chromosomal aneuploidies that needs to be ruled out, especially if there is a counseling towards advancement in the pregnancy, aiming for a separation later on. The prenatal assessment for surgery or separation earlier, it may identify the need for an emergent separation at birth, and this is usually will arise when one of the twins is carrying a major impact on the surviving twin, or an immediate surgery is needed. So this needs very well to be prepared in hands before, and this possibility should be discussed with the family prenatally and with the MDT team to be prepared for OR once accurate diagnosis and anatomy and vascular connection had been in place. These are some of the counseling things that probably an MDT would carry or look at along with the family. Is the surgical separation is feasible, and what is the prognosis of the separation for both fetuses, and what prognosis for both fetuses with a non-separation if separation surgically is not, so what would be the prognosis for them, and the nature of the surgical procedure and the potential risk and benefits, not to overlook the importance of the psychological and economic impacts for kind of this surgery. The teams involved, Dr. Namshan already mentioned the MDD team, and these are just a list, and probably you can expand or add to this list based on what is the exact they are conjoined for. The prognosis, it is influenced primarily by specific site of fusion and associated anomalies, and this is very well understood, that it depends on where they are fusing and if there is any other associated anomaly. Generally, the general, I would say, prognosis given to craniovagus probably, or if there is a conjoined twin with a sole cardiac mass or a major complex cardiac connection, usually they do have or carry the worst prognosis. As I mentioned, other associated anomalies are not uncommon, and probably cardiac anomalies are the most common part of it, and being present in almost 90% of the cases, especially if it is ventral conjoined twin. Other anomalies are in different percentage, but again, this is just to emphasize that it is not only a conjoined twin, it's a conjoined twin with other anomalies that needs to be looked at, diagnosed early, and anticipated very well before to giving the prognosis to the parents and to the team separating them. And in general, in their study, it had been estimated that 40% of the conjoined twin are usually stillborn, and 35 will die in their first 24. Actually, the survivor for the sets of twins had been worldwide by the study, showed only 6 to 8 sets of conjoined twin had been making it so far in neonatal surgery after 1 year. Now, once diagnosis is confirmed, all parents should be referred and offered a termination of pregnancy if legally permitted. And we do have in Saudi Arabia, we follow the general guidance of our Islamic scholars that termination of pregnancy can be allowed if it is less than 19 weeks or whenever major jeopardy or maternal health is jeopardized, then at any given time. So those patients usually needs to be referred to a tertiary hospital where these decisions and sharing, also discussing this with the ethical committee is encouraged. If termination is not permitted, or if the patient desires to carry the pregnancy, and then still accurate prenatal diagnosis of any lethal abnormality allow the parents time to prepare for birth, where they're going to be delivered, and what preparation they need to do in the case of demise of their twins, and the mode of delivery, and trying to minimize the trauma to the family, either physical or mental trauma. And to also plan a palliative postnatal care, because not all of them will die immediately, so where this palliative care will be given also is very crucial and important. Now, management option, I talked about termination of pregnancy and could be non-medical, which is medical, which is non-surgical, and can be offered up to 20 weeks of gestation. An earlier termination definitely will minimize the risk of maternal morbidity, at least to avoid a hysterectomy or a cesarean section, especially for the lethal part of conjoined twin. Very important that patients will go for pre-procedure counseling, and induction of termination should include all prenatal and potential risk, and it should be done in a tertiary hospital where the physicians are involved are truly available and are experienced enough to deal with those difficult cases. Different modalities of either medication or non-medicated way of inducing miscarriages and can be offered at any given time. Now, for the surgical termination, usually it's the gestational age and availability of clinician trained in surgical termination is very important. And when I talk about surgical termination, I mean evacuation curettage or dilatation curettage, or in some cases, a hysterectomy that's beyond viability of gestation or when termination is allowed. So again, it needs the experience of the attending physician, the obstetrician, and the center is at least very well available to deal with these cases and for any other surgical complication that might arise. Now, if parents if the parents choose to continue the pregnancy, or if we're continuing the pregnancy because there is a good chance for them, for the conjoined twin to be separable later on, so there is no clear guideline how we are gonna to follow those because of the rare conditions of this situation. And there is no much, I would say, evidence to look at what kind of care. So the clinician should assess the expectant parents, their value when creating the care for plan. Consideration should be given to what pregnancy outcome are acceptable for them. Now, how usually we follow them? Usually we need to understand that those conjoined twin, they are at risk of stillbirth in 40%. So meticulous and more close follow-up needs to be given. And there is also increased risk of preterm delivery, and this is also for any twin gestation or multiple gestation, so needs to be looked at, either spontaneous or iatrogenic for any other indication. Serial ultrasound should be done by maternal fetal medicine to monitor the growth, fetal Doppler, and looking for any signs of heart failure, and later on for the position of a twin in preparation for delivery, so to map where the incision or how the incision of cesarean will be done. Usually we advise visits as an outpatient to the antenatal clinic every 2 weeks. And we intensify our weekly antenatal testing to be twice per week after 32 weeks. If interval growth and Doppler evaluation or antenatal testing are not reassuring, then dexamethasone or betamethasone administration to accelerate and prepare for the delivery should be discussed and balanced against the risk of stillbirth with an ongoing expectant management and against looking at the risk of preterm labor. Third trimester MRI before the delivery also is advised to just aid in the confirmation of the diagnosis and the plan. I'm not going to take a detailed time about the delivery plan before or pre-delivery plan. Multidisciplinary team approach, as mentioned by Dr. Namshan earlier, is very crucial, and the team description had been given also. Simulation is very invaluable in preparation for the delivery for all team, including obstetrician, maternal fetal medicine, along with the team attending. On the day of the delivery, we recommend 2 main teams, an obstetric team led by a senior obstetrician along with another obstetrician. Neonatology team, definitely 2 teams is needed, included NICU consultant, his assistant, and a nursing team from NICU. Clear delineation of the responsibility for everyone in the delivery room, and to make sure that attention to be given to looking at the balance of crowd in the OR, and many times these are cases that require multidisciplinary team, so their presence in the OR might take a lot of anatomical space. So this needs to be looked at and to be managed and making it more of an easy flow. Very important for our pediatric anesthetist is to look at if there is any possibility of contingency plan for an airway management if needed on time. Mood and time of delivery. In practice, most cases delivered will be planned between 34 and 36 weeks, and usually after steroid for lung maturity. For conjoined twin in third trimester, the recommended mode of delivery is a cesarean section, regardless of the plans for neonatal care. That's to say, even in the cases of non-separable one third trimester twin, conjoined twin, delivery should be cesarean section. Now, in the literature, what they mentioned about the surgical incision is they talked about either doing a vertical skin incision and classical cesarean section, up and down incision on the uterus, or it could be a vertical incision on the abdomen with a lower mid-transverse or even lower vertical. In our center, we had a couple of those cases referred to us as a pregnant patient, and in most of the time, all of them, we managed to do a lower transverse incision or fan-style incision on the skin and on the uterus, and it was successful with no problem. For an exit procedure, as mentioned earlier by His Excellency, the need for it needs to be looked at and anticipated before the delivery, and this will aim only to support the continuous oxygen supply till airways are maintained or managed without any problem before they are transferred outside the maternal uterus. Immediate cord clamping is advised. These are the other issues that probably we don't need to overlook, and maybe we need to look at in looking at those cases: informed consent, prenatal rights, quality of life, especially for cases where some of the conjoined twin, one of them might be surviving and the other one might not survive, and needs to be looked at and discussed with the family. Moral dilemmas, and I think this is case by case based on what kind of conjoined twin, ethical consideration, and it will be good if each institute or if the institute has their ethical committee to discuss. And we had this practice before, and having a multidisciplinary, including an ethicist, to discuss these cases. And the last is providing emotional support for the family. This goes without me saying, and this is very important. We saw today in the video that had been shown today how was the family emotion before and after, and once they got reassured about their babies, how much they are, kind of in emotion for that. And the coping strategies, and make sure that the parents are coping, and even the children themselves as pair are sharing. I'm going to take a couple of, just to share with you, these are 3 cases that we had recently in the last 2 months only had been referred to us. This is the first case, is a 32-year-old prime-gravid spontaneous pregnancy, was referred to our clinic at 17 weeks with a report of a triplet gestation with 1 set of conjoined twin for further counseling and management. She was seen in our clinic and scanned, and ultrasound showed a triplet gestation, 17 weeks, monochorionic, diamniotic, with set of conjoined twin, thoracoomphalovagus, single heart for the conjoined twin, and the other one was a normal third triplet. Now, the counseling had been given because she is a monochorionic. They are sharing 1 placenta, so the risk had been explained for them, and entailing that the risk of either death of all, risk of TTS, and also if there is any intervention, that probably they might lose the whole pregnancy. Parents choose for an elective termination, and they were electively terminated by medical point. And to mention that triplet conjoined twin is a unique, and the cases that had been published, I'm not going to go in detail, just I want to draw your attention to the kind of twins. If they are mono-di, the risk of losing the whole in a triplet is very high. Very successfully only done for the di-di one, where the vascular separation or circulation is more. So this case, she's still on board, and she's now 31 weeks, but she had been seen in our clinic, and we with a single, with a heart and a rudimentary other heart, but with a major vascular connection between the two. She's now 31 weeks, and we are still on follow-up with her. And there is already a multidisciplinary team had been carried out. The last case I want to share with you, this is our last successful delivered one. That was 16 days ago, and that was an SQ Vegas conjoined twin, and had been delivered recently, and they are waiting for a separation. They are candidate for it, as base discussed on our team. So in conclusion, Conjoined twin is a rare event which is a unique complexity for an obstetric management. Provision of coordinated, expert, and compassionate care required extensive mobilization, and early referral when possible allow for timely counseling, exploration of patient value, and a fully orchestrated team-based prenatal delivery plan will improve the quality of that. Thank you very much.
Our next speaker is Dr. Yasser Gazzaz. He's an associate professor and pediatric intensive care consultant at King Abdullah Specialist Children's Hospital at Ministry of National Guard. Now, the talk is about postnatal care. Thank you.
Assalamu alaikum. Good afternoon, everyone, and welcome. Today, it's an honor to be here at the International Conjoined Twin Conference. And before I begin, I would like to express my attitude for the Saudi Congenital Twins Program for organizing this conference and for the scientific committee to share our insights and learn from our distinguished speakers. So today, I'm going to be talking about the postnatal care for conjoined twins. And I would like to start actually with the last slide that I'm going to share with you. There are, as shared by my previous colleagues, there's a lot of medical challenges, and we'll go through them, but not all challenges are medical for those conjoined twins. Has to be a proactive approach, as has been mentioned by multidisciplinary team and rehearsals, and that's we have to leave no room for the unexpected. And multidisciplinary team is emphasized. A united team is greater than the sum of its parts. And for NICU or neonatal patients, we have standard of care. We have pathways like NRP, but for those unique conjoined twins, sometimes the right thing is to rewrite the rules and to redesign the rules. So just some facts that has been shared, but I'm just going to share the mortality. So there's a different mortality that varies between 40 to 60%, and most of those twins, if they die early on, they die in the first 48 hours. Patients who undergo separation, this is from a US database that includes 250 conjoined twins. The mortality was 33%, so 1 out of 3. Thoracophagus, there's some associated with higher mortality, like thoracophagus, because of the shared heart and the congenital heart disease that comes with it. And associations with mortality includes prematurity, mainly associated anomalies, and basically where those patients are managed. So as been emphasized before, the delivery should be in a tertiary care center with the multidisciplinary team that's going to discuss proactively those patients, neonatologists, pediatric surgeons, soldier service, rehabilitation, dietitians, nursing, and pharmacy, and even more. Patients, conjoined twins at birth, they can be grouped or separated into 3 categories. Those that, unfortunately, separation cannot be done when there is complex either cardiac fusion or cerebral fusion. And sometimes there has to be immediate separation when one twin is threatening the other. And that's when one twin is not receiving, for example, adequate perfusion because of the cardiovascular system. And preferred, of course, a delayed separation when those patients are stable. So I'll start with not all challenges are medical, and conjoined twins carry a unique challenge to the medical team because their anatomical variability, every set of twins, as you see, is completely different than the other, which requires a very customized care and customized plan for them. Some of the challenges, I would like to start medically, mentioned airway considerations, cardiovascular considerations. Those are the major because they really determine life or death. They're inherently difficult airway because of their orientation, and I'm sure anesthesia is going to talk about this. Cardiovascular considerations when they share cardiac structures, and simple things like knowing the heart rate for each set of twins. So there might not be a space to put cardiac leads after they're born, or even difficulty on differentiating the heart rate by auscultation. Those patients come with different congenital anomalies. Cardiac defects are the most common. Some of those defects are lethal, like CDH. I could not find in the literature any pair of CDH patients who actually survived. It's lethal. They come with esophageal atresia, abdominal wall defects, orofacial defects. But really, Other than the medical complication, there is 3 ergonomic challenges for the workspace. So ideally, neonates are transported in incubators, but those incubators might not be large enough for those neonates. They might be large enough to accommodate all the equipment that they come with, to have an access for those patients. So different beds can be used for those, maintain temperature while maintaining access and space for the equipment that comes with them. The layout of those has to be clearly designed. Where are the healthcare providers and the machines? I'm going to show you an example. Simple things like color, like coding for patients. Or twins, usually they are designated twin A and twin B, but this might lead to confusion. And color coded has been advocated too. And this color coding is for the patients and for each of them, their equipment. That includes ventilator, the medications, even the blood works or the lab test that's been done to them, and even in communication. So orange patient, oxygen saturation 60%, for example. In terms for space for those patients when they are provided there, so there's a lot of equipment and manpower that has to provide care for those patients. And in emergency situations, we need to move some of the equipment, like the IV poles or the ventilators. So those are meant to be at the sides where they can be easily mobilized away for emergency situations. Of course, there should be care about visibility of monitoring, designing a space that those patients are going to grow, and bigger space they're going to need. Positioning, they have to be positioned every 2 to 4 hours, which can lead to tangling of IVs and airway equipment. And of course, privacy is an integral part for those conjoined twins and their families, and not to invade their privacy. And a single room is advocated, keeping in mind we need a large space for those patients. Leaving no room for the unexpected, so there's a lot of planning and rehearsal and being proactive than being reactive for those patients. Medical considerations, as we saw, those patients will have antenatal imaging, MRIs and ultrasound to delineate their structure, the expected other anomalies, if they share circulation, the equipment, the personnel, the space, the emergency planning, and of course I'm going to focus on training and simulation. So in terms of simulation, we saw that rehearsals occur, but it has been advocated, and this is the experience from Texas Hospital, where 2 modes of simulations are done. So those conjoined twins, as we saw, it's a planned cesarean section to have them. So 1 month prior to delivery, you do simulation, and just in time, so on the same day where their delivery is expected, simulation is located in the same place, that the same room that is going to occur, and it goes over everything. It's a 1 to 2 hour simulation that goes between stable patients to resuscitation, how we're going to provide positive pressure, and even providing access. And as you see, constructing of the mannequins is based on how the ultrasound and MRI looks like, and now there's 3D printing that can be used. A united team is greater than the sum of its parts, and Dr. Amshana already has alluded into this in the surgical team, but as well there's the primary care team in the NICU or the intensive care. Between primary nurses, nurse leaders, clinical nurse specialists, neonatal nurse practitioners, physicians, dietitians, social workers, physical therapy, there's a huge team that covers for those patients. And primary nurse is an integral part of this. Primary nurses are going to be 2 to 3 nurses who are providing care to those patients continuously. So basically those patients will not have multiple nursing team taking care of them. They have a solid 2 to 3 nurses, and that's improved the quality of care. It's a patient-centered care. It's actually create a rapport or a trust with the families. And those nurses, when they're continuously there, they can catch up on the subtle changes. Some of those patients, as we know, when they share some circulation, might not be very evident, but they will notice giving medication, like I said, if to one patient, is going to affect his sibling. A team, so a resuscitation team, and that's when I talk about the patient who are delivered, not in the NCU, so preparation for the delivery itself. So there are usually 2 team leaders, although at birth, if not needed, only one is going to be leading the team. Otherwise, they're going to be confusing between the management, airway provider, respiratory therapists, circulating nurses, documenting nurses, medication, and managers. And again, the planning of the location of those physicians and equipment has to be really studied between, again, a team leader inside and a team leader B outside who's helping airway for both patients, RTs, and circulating nurses. Nurses can provide medication. The documentation of those cases, of those patients requires resuscitation. And of course, there's a nurse outside who's going to provide and prepare medications. Doing what's right sometimes mean rewriting the rules or breaking the rules. For neonates, a neonatal resuscitation program is actually a structured training program that's designed to teach healthcare professionals how to provide care and medical care, resuscitation care, and emergency situation after birth. And those has to be remodified for our population. Few things that we have to consider: how we're going to monitor the heart rate, airway management, chest compression, access, medication dosing. So heart rate, as you see, the whole algorithm for NRP depends on heart rate at some straight off of cut points, but sometimes there's not enough space on the chest to put leads or even to appreciate heart sound of each twin. So if that's not possible, it's advocated to place actually pulse oximetry in each of the patients, not for saturation, but it's going to give you a waveform for the heart rate, and that's going to dictate how we're going to perform the management. Airway management, again, from the US database of around 250 patients, 1/5 of those patients, so 1 out of 5 of those conjoined twins couples are going to require intubation. And this intubation is as tricky as it is in the OR. So sequential intubation is recommended, so the sickest child first, to get it easier to be done. Usually it's done in lateral decubitus, not we are used to when the patient are supine, and LMA is a feasible alternative for those patients. Chest compressions, so again, depends on the type of twins, but the recommended by NRP is, again, it's a thumb resuscitation. We're supporting the back with the rest of the hand and the fingers, which might not be possible to wrap the hand around the patient. So again, a 2-finger technique is discussed, and this is discussed ahead of time. From Philophagus twins, for example, if it's a one infant, they can be repositioned, one of them on their back to do 2-finger technique. Or sometimes if they're both, actually the heart rate is below and they require both chest compressions, what has been discussed is placing them on top of each other, and the chest compression is done on the knee on top. Medication dosing, so those patients, as we've seen, there's a high chance of them sharing circulation, whether it's a direct vascular circulation or a liver that metabolizes medications. When there's concern for cross-circulation, what is the recommended? So using the combined dose to give it to those neonates, so instead of taking their total weight and divided by 2, so combined dosing is recommended when you know about shared circulation. For emergency medication strategies, there are 3 options, either when it's a arrest situation, either 2 doses and each child is going to receive one of the doses, or each neonate, or actually we give a full dose with a full weight for the neonate who's decompensating, or just alternating, and that has been advocated too. So one twin is going to get the full total weight dose, and the other access is given to the other twin. Vascular access, so what really is optimal is to have a readily accessible access to deliver medication to the intended twin, and that's a key. So thoughtfully, if the connection is not from above, the upper extremity seems like a good access, with the upper vasculature draining into the heart directly, so it's an advocated to give. If that is not possible, IV, IO, an umbilical vein again can be used. And that concludes my talk. Again, the key messages here, that the challenges, yes, we have to focus on the medical, but rehearsal for the other stuff is as important. It's a multidisciplinary team effort. It has to be well planned. Simulation is useful, and we have to readjust to each set of twin differently. Thank you.
Thank you. Well, our final speaker for this session is Dr. Futun Al-Otaibi. Dr. Al-Otaibi is the General Pediatrics and Complex Care Consultant at the King Abdullah Specialized Children's Hospital, Ministry of the National Guard Health Affairs, and she'll be giving us a talk on the care of conjoined twins before separation. Welcome, Dr. Al-Otaibi.
Your Excellencies, or dear respected guests, Assalamu alaikum. I'm honored and privileged to be here today, especially on behalf of our team in complex care, who usually takes care of the conjoined twins before and after separation. Why complex care? Well, our team specializes in children with multiple chronic conditions who need technology assistance to sustain life functions, Our patients have multiple subspecialty involvement, and also they need high level of care coordination. So that makes us the most suitable host for such patients. When thinking about the preoperative phase, one might think that's a single phase before keeping patients in PO, but actually, especially in the context of conjoined twins, it's a multi-stage process where each stage has its own set of objectives. During all of these stages, we maintain, as Dr. Nemshan has beautifully mentioned, the MDT approach. We're an MDT team by ourselves. We have our own nursing coordinators. We have respiratory therapists, rehabilitation services, and also we maintain our consultative approach with our surgical specialty, radiology, anesthesiology, and so forth. And also from day one, we usually involve family through shared decision making. You can think of the preoperative phase as a timeline that usually starts as early as before the twins arrive, since we receive the report, and then upon their arrival, we take care of them and we do our thorough assessment, including history, exam, laboratory testing, genetic testing, and we start including our colleagues in the other services, including neurology and cardiology. And then all the way till the day of separation, we focus mainly on nutritional support and optimum growth, and also, as I mentioned, shared decision-making to empower the family. So before their arrival, usually we receive the reports, we read them, we start our communications with our colleagues in surgery, and then we're basically ready. And then when they arrive, we do our thorough history looking for any active issue that might interfere with anesthesia or surgery, such as like asthma, reflux, anemia, and all of these things. And we keep in mind the cultural differences and endemic risks, so we also screen for any ongoing endemic conditions in our home country. We do our meticulous head-to-toe exam looking for other congenital anomalies, and we do our routine workup, assessing their hemoglobin level, renal function, liver function, and we involve our colleagues in the genetic and precision medicine to look for any genetic anomaly that might explain the twinning or other anomalies. We involve our colleagues in neurology for a baseline neurological assessment to inform the decision when going for high-risk surgeries. And then I believe our colleagues in cardiology will cover this beautifully, but we involve them to assess the cardiac function, and usually the cardiac function is used to risk stratify. So when one of the twins has a cardiac lesion, they're usually labeled as blue, the other one will be labeled as pink, but as Dr. Gazaz mentioned, sometimes it's tricky. And then you cannot be a pediatrician without providing vaccinations and updating them. We usually either ask for the card or we involve our colleagues in infectious disease to provide us with a catch-up schedule if the vaccinations are delayed. So, and of course, based on the level of the conjoined twins, we involve our colleagues in surgery. For example, in craniovagus twins, we involve our colleagues in neurosurgery and plastic surgery. In thoracovagus twins, we involve cardiac surgery and general surgery. And of course, omphalovagus twins necessitate general surgery and plastic surgery involvement. And on the other side of the screen, you see the multiple radiology modalities requested for each specific type of the conjoined twins. And I believe our colleagues in radiology will cover that in full detail, but as you can see, echo is almost always a part of all the images, again, to risk stratify. And then that is the main focus of pediatric care before surgery, it is to optimize growth and nutrition. We usually aim for a combined weight of 18 to 20, although some centers use 10 kg as a cutoff. However, we need to keep in mind that assessing height and weight in conjoined twins is tricky. We have the abnormal position, we have the discordant growth. One of the twins may be obviously bigger than the other one. However, in our calculations, we use the half weight, exact half weight. And then we've observed a syndrome in most of our conjoined patients when they have these differences in growth. That is the extraterine twin-to-twin transfusion. And as Dr. Gazaz has mentioned, shared circulation is an issue in conjoined twins, whether in their critical post-op phase or even before that. We've seen cases where one of the twins will be, for example, hypertensive, the other will compensate by being hypotensive. We had cases where one of the twins had a clear renal failure with no urine output. The other twin magically will take over and be polyuric in a syndrome that's called autodialysis. This is the paper I'm talking about. So this is still under press. Our team studied almost 10 sets of conjoined twins. Almost 70% of them have this extrauterine twin-to-twin transfusion when one is visibly bigger than the other, and also up to 40% of them had an element of shared circulation. Other part of the nutrition is the challenges that comes with being conjoined twins. So as you can see here, this is one of our omphalobagous twins, and mom was really frustrated because she cannot feed them both with a bottle feeding at the same time. So our creative colleagues in and occupational therapy took over and came up with this way of bottle feeding them at the same time without using bottles because there's no space. So even though we can come up with these things, abnormal position is still an issue. We've noticed issues with swallowing solids in craniovagus twins because of the abnormal neck position. And we usually involve our occupational therapists, physiotherapists to come up with specific cushions or seating positions to help with that. And also we do our own swallowing assessment pre and post surgery to see if that has changed. And as I said, we need to feel, make the family feel empowered by involving them from day one. We keep in mind the cultural differences. Sometimes we have non-parent sitters, which makes things a bit difficult. But however, we keep all of that in mind. We involve our translation services, and we try to keep the family updated as much as possible. Family members are part of all of our MDT team meetings, and this is a model that we usually follow in case of shared decision making, which applies when we have two options that have the same burden and benefit ratio, but I think things are much complex when you have a complex high-risk surgeries, and if that's the case, we involve our colleagues in palliative medicine and also ethics if needed. Our psychosocial support continues. So in addition to the support we get from social services, we have the specialists that train in making all of the medical information understandable in an age-appropriate way. Our colleagues in child life specialists usually involve and try to explain everything to the child. Play therapy has been used to eliminate a lot of the stress and anxieties before surgery. This is one of our toys, Surgery Bunny. This bunny has been to every OR you can imagine. It has an IV line, a PICC line at one time, an NGT, so Surgery Bunny has seen it all. With that, I conclude my talk today. Special thanks to Dr. Hamad Al-Khalaf for his input, and thank you all.
We are running late, so we'll allow 5 minutes of questions, please, only. Yes, please. Microphone there.
Assalamu alaikum. Saud Al-Jadaan, pediatric surgeon at National Gant Hospital. My question is to Dr. Namshan. You mentioned about assembling the team, and at one point, those new members will probably take over if somebody leaves or for any other reason. Did you see or find, or did you study any change in the rate of complications or something when you have other members of the team joining? Because as you know, every procedure, we have lots of requests from people at different levels, trainees, consultants want to join. Did you see any change or an increase in the complications? And the other question is how to avoid it. Thank you.
Thank you for the question. We have seen it, no, because as you know, the team over the last probably 30 years, the replacement of the living people was gradual. So the new colleagues were integrated in the team earlier. So what their colleagues, the expert people, left the team, the new generation had gained the experience with the support of their colleagues from the other specialty. We avoided this one. And also in the area that we feel really we need a help on it, you remember, we don't hesitate to ask an expert from outside to join the team. For the trainee and the junior person when they join the surgery, it gives them an experience not only in the conjoined twin surgery, but also in their fields. They look at the system, they look at the cooperation, they look at the management of the complex cases, they look at the coordination. It's beneficial for them, not necessary to join the team, but also in their specialty.
Yes, please.
Assalamu alaikum. Good afternoon. My name is Dr. Saad Al-Malham. I'm a pediatric surgeon. If you allow me, I'm going to ask two questions. The first question is to Dr. Rabia. A lot of work has been done over the last 35 years, thanks to your efforts. My question to you is, I know that the sky is the limit. When are we going to see in our institution here a center for the advances in this type of complex surgeries, such as 3D printing, artificial intelligence, the simulation-based clinical rehearsals, etc. I think we can do so many things since we are the best center in the world, including a museum for twin separation. So when are we going to see this coming up? I know there are a lot of work being done, but when are we going to see it? Before I leave the microphone, let me ask the second question. My second question is to Professor Oloteo, which I would like to welcome to his visit to Saudi Arabia. Professor Oloteo and he trained me for pediatric surgery at Texas Children at Baylor, so thanks to him. I'm a pediatric surgeon now. I know you're you're an expert in fetal surgery and exit surgery. Where does it stand now, and where is it going? What are the new things, and where do you see it in twin separation? Thank you.
Well, thank you, Saad and Dr. Saad Al-Mulham. Well, let me first of all, the 35 years of success, I don't take the credit. It's a lot of people who are actually sharing that credit, and quite a number of them are here with us, so I thank them also. But going to the future, if you look when we started 35 years ago and now, every time there has been an improvement, not only in the know-how, not only in the techniques, but also in the technology. And with the commissioning of King Abdullah Specialized Children's Hospital, and the technology in the hospital, and the dedicated operating room and digitalization, I see it's not far from being here, whether it is related to the utilization of 3D printer, which is very quite easily possible if it's not there already, and also the utilization of the virtual technologies. Dr. Namshan mentioned using it in the meetings, but we could also use the virtual involvement of some surgeons virtually. So these are things that are happening. The research part with the presence of the King Abdullah International Medical Research Center is also makes it easier to happen, including having a model, a modulation room, and you name it. For the museum, many people talked about it, and it is in our mind. I'm sure it will happen. Now let's move on the platform and the website, make it a global, and it will be followed, inshallah, by the museum. Thank you.
Well, I'll make this quick since we're almost out of time. But again, thank you, Saad Al-Mohim, for the nice welcome again. Glad to be back in the kingdom. So fetal surgery is on the move and their potential benefits. Again, I think the important part was what Dr. Al-Rabi had said earlier on. Prenatal diagnosis is the key. None of this can happen without appropriate prenatal diagnosis. As you've heard, many of these conjoined twins are not even diagnosed prenatally. And so fetal surgery is not even an option if you do not make the diagnosis before birth. So that's the first aspect. How can we improve access for women to have prenatal care, prenatal diagnosis? Now, when that's done, you can imagine even after birth, when you have all the tools available to you, the complexity of separation of conjoined twins is a big deal. You can multiply that by several factors to now do it prenatally. And so, yes, it's something that there's potential for, but I think a better understanding of all the nuances and who would benefit. Care is still best given for any fetus with an anomaly after birth, but a select group would benefit. And so to identify those that can die prenatally that may benefit from fetal surgery would be the key, not just necessarily to operate on every conjoined twin before birth. But I think that's an important concept for the future to talk about, and maybe if time permits, we'll talk about it in the break. But thank you again for the warm welcome to the kingdom.
Okay, thank you, everybody. We are about 10 minutes late. The next session was supposed to start at 3:20, and now it's 3:10, so we'll make the next session 3:30 so that we have time to prayer and have something to eat. Thank you.
Good afternoon. I'm going to introduce session 2 for this afternoon. Our first keynote speaker here is Dr. Felice Darko. He comes to us from Great Ormond Street. He's a professor in neuroradiology. Before that, he was from Toronto, and that's my
كان قبل ذلك في
Vancouver in Canada. I know we're a little bit behind in time, so without further ado, Dr. Felice, the floor is yours.
Hello, and thank you very much. I would like to thank the organizer for inviting me. My name is Felice Darko. I'm a pediatric neuroradiology consultant at Great Ormond Street Hospital in London, UK, and I would like to speak about multiparametric imaging for presurgical planning of craniopagus twins. So this subset of twins that are joined by their head. And first, I would like to share our experience. This is the case of total craniopagus twins that were examined, and most of them separated at Great Ormond Street Hospital. And these are the countries we were working with in collaboration with during the years. Now, we have heard already about epidemiology. Just I wanted to stress that the conjoined twins are rare, as has been said, but craniopagus are extremely rare. And what does it mean for a radiologist? It means that basically we do not have standardized CT and MRI protocol for preoperative planning of these complex cases. Now we have protocols for everything: epilepsy, tumor, neurogenetic disorder, standardized guideline. This is not the case for the craniopagus twins because of their rarity. And also there are very few centers with previous experiences. So there are very few people to ask with and to ask to when you have a problem and you are planning a particularly complex case. And as I say, there are no radiological guidelines available. So what I'm presenting now is our effort to establish these guidelines. So we joined together with the Rome Children's Hospital. Rome and London are the biggest center involved in separation in Europe of craniopagus twins, and we wrote down the guidelines for multiparametric imaging for presurgical planning of craniopagus twins. The important thing is that this is not a final point, that's a starting point, and events like that are really important to start collaborating with you and with other institutions with expertise in this field in order to improve